So a huge welcome to everybody joining our Surrey and Sussex Cancer Alliance webinar to discuss inherited risk of pancreatic cancer surveillance, and the European Registry of Hereditary Pancreatic Diseases. So next slide, please. My name's Kat Hodges, and I am the primary care lead for the Surrey and Sussex Cancer Alliance. And we are very, very lucky today to be joined by some amazing guest speakers who are experts in this area. So I'm very grateful for them taking the time to join us today and share their knowledge and experience. So we have Emma Hirst-Williams, who's the Senior Strategy Manager at NHS England. We've got Professor Chris Halloran and Annabelle Boughey from Europac. We've got Dr. Helen Winter, who's a consultant medical oncologist and the clinical director of SWAG Cancer Alliance, Peter De Rosa from Pancreatic Cancer UK, and Kim Kay, who is a patient participant, and we're very, very grateful to her for joining to agree to tell her story. And I think it will really highlight the importance of the work that we are doing going forward. So next slide, please. So just a brief overview of our agenda today. I'm going to give just a little bit of context around why we're here, and then hand over to our speakers to talk about some of the objectives for Europac and an overview of it, that secondary care perspective, an update from Pancreatic Cancer UK, and the patient story. We will have time for question and answers, so please do put those in the chat and we will try and get through what we can. If we overrun, then we will collate these in a Q&A and send those out after the event. So next slide, please. Just a little bit of housekeeping, just to say we are recording this today and we will circulate it with the slides. If you're not a speaker, then please do keep your camera and your microphone on mute. Pop all those questions in the chat box. And just to say, we will have a feedback survey at the end of the webinar, so do have your mobile phones ready and you can access that via a QR code, and we'll pop a link in the chat as well. So next slide, please. So I think none of this will necessarily be new to people, but I just wanted to kind of remind people some of the statistics around pancreatic cancer and why it's so important to work to diagnose it earlier. So we know it's challenging to pick up at that early stage, and more than 80% are not diagnosed until an advanced stage, with over half of those being diagnosed via A&E. And sadly, the survival in the UK has not improved in the last 40 years, and we have poor outcomes, with only 1% of people diagnosed with pancreatic cancer today predicted to survive their disease for 10 years, and less than 8% beyond 5 years. But if we can pick up and identify these patients early, and when surgery is still an option, then that survival beyond 5 years increases tenfold. So there really is a possibility to improve outcomes in this area. Next slide, please. I just wanted to highlight to you a resource tool. So at the Surrey and Sussex Cancer Alliance, we've developed a toolkit, and this is available on our website, and we'll link to it in the chat. We've broken it down into different chapters covering the challenges and importance of early diagnosis, some of the national and local data, risk factors, new onset diabetes and pancreatic cancer, some online support tools covering the inherited risk of pancreatic cancer, and then links to useful resources and training. So please do take a look at this for some further information as well. But without further ado, I'm going to hand over to Dr. Emma Hirst-Williams to talk about the NHS England objectives for pancreatic cancer surveillance and Europac. So thank you very much, Emma.
Great, thank you. I'm just waiting for my slides to load. Can you all see those? Say nodding, great, thank you. So thank you very much for inviting me today, and for all of you attending. This is wonderful. So I'm, as Kat said, I'm Emma Hirst-Williams, Senior Strategy Manager in the NHS Cancer Programme. So we are the national team responsible for delivery of the cancer ambitions in the long-term plan, and have national oversight of the pancreatic cancer surveillance project that you'll be hearing about today. And I'm going to keep this very quick because we have an excellent lineup, and I very much see myself as the warm-up act to Kim at the end. So for context, when you look at all cancers, around half of cancers diagnosed at an early stage, and this has really remained static for at least the last decade. And the long-term plan has set the ambition to increase this to 75%. To get to 75%, we're going to need to make progress across all cancers, but especially those that are often diagnosed at a late stage. And as you can see from this first graph here, there is really significant variation by tumour type. So my role is to develop our early diagnosis project pipeline, so looking for opportunities where we can improve diagnosis of cancer. And one of the ways we do this is through our tumour site reviews. And so these are deep dives into a particular cancer diagnostic pathway to look for opportunities to improve early diagnosis. And we really focus those on the tumour sites within the kind of red and amber sections of that graph here. And so the project that you'll hear about today came from our pancreatic tumour site review. So as Kat has already introduced, of course, you probably don't need to hear this, but we really need to move the dial on pancreatic cancer. So we have around 9,000 cases a year in England. 3/4 of patients are diagnosed late, and due to late stage diagnoses, only around 10% can have surgery to remove the pancreatic cancer, which of course gives the best chance of a cure. And it's also a cancer with a particularly poor prognosis, and we are really lagging behind other countries as well when it comes to outcomes. And so one of the projects that we're taking forward from the pancreatic tumour site review is this joint piece of work with Europac. So around 10% of all pancreatic cancers are caused by hereditary factors, and clinical NICE guidelines already recommend surveillance for people with inherited high risk. And so surveillance for these individuals offers the opportunity to detect early or even ideally prevent pancreatic cancer through identifying and managing lesions. So NICE guidance includes criteria for who's eligible for surveillance, but it doesn't provide a protocol for how and how often. And when we looked further through into this using our review, we found that trusts don't currently hold lists of patients who meet the criteria set out in that NG85 guidance or have surveillance services to offer these people. So as a result, many eligible people are unaware of their increased individual risk and are not undergoing active surveillance unless they're involved in the Europac study. So I'm not going to go deep into this because that's for Chris Halloran to go into, but essentially Europac are a registry, and they also run a study testing the efficacy of a surveillance protocol to meet that NG85 guidelines, and while doing so they are offering surveillance to high risk individuals. So right now, the majority of people within the Europac study have self-referred, and what this project really is all about is establishing these referral routes from the NHS, so we can have processes in place to identify eligible individuals, and so that really surveillance is actually standard of care, as it should be already. So to do this, we are funding Europac surveillance navigators initially for 12 months. And they will provide a route from the NHS into Europac surveillance. So a very kind of quick overview of that. Essentially, kind of staff in secondary care, genetic services and primary care will be able to refer eligible patients into these surveillance navigators. The navigators will then conduct a risk assessment, enroll eligible individuals and manage all of those surveillance activities, including contacting patients, arranging appointments at their local surveillance centre. And based on that risk assessment, patients then have a checkup, so usually annual, and any actionable findings are referred to their local hospital. And so we're also, the national team are also working with Pancreatic Cancer UK, who will be speaking a bit later, to improve awareness and recruitment during this pilot as well. So that's mostly what I want to say. I just finish off with saying that I am a really huge advocate for this project. I think it's an opportunity to potentially prevent and diagnose early up to 900 cancers a year, so offering the chance to really improve outcomes for patients. So yeah, thank you for having me, and really looking forward to the rest of the presentations. Thank you.
Thank you very much, Emma. It's great to have you set the scene as to why we really need to shift the stage of diagnosis for pancreatic cancer and highlighting the background to the Europac study. So huge thanks for joining. I'd like to now introduce Professor Chris Halloran, who's the clinical lead at Europac, and Annabelle Boughey, who's the operations manager there, to give us a further overview of Europac. very lucky to be joined by you today.
Thank you. Could I have my slides, please? I should say that also I am a pancreatic surgeon as well, so I see this at the bad end of the disease more often than not. Next slide, please. So as Emma just said, the tumour site reviews have got a couple of cancers that they want to look at, but fortunately or unfortunately, whichever way you look at it, pancreas cancer is the first to be revealed. So hence why we're working through this. I think it's probably just worth spending a few seconds on the difference between early diagnosis and early detection, because the two are not the same thing. Early diagnosis just means in reality you're diagnosing a tumour earlier than you would have done, so any apparent length of survival is actually a lead time bias and isn't real. But really what the idea of Europac is to detect precursor lesions before they become cancer, deal with them before they become cancer, and prevent a patient from getting pancreatic cancer. That is the point. Next slide, please. So as Emma mentioned, essentially Europac is a registry. It was set up nearly 25 years ago by one of my predecessors, and the registry portion of this research is funded by PC UK, which this time last year consisted of Annabelle and myself and Bill Greenhalgh and a research fellow. If I have the next slide, but what we also do through other programs is that we are a research program apart from just a registry. So we're running a program called Europac Plus, which is basically designed to give our patients both a family risk and a germline DNA risk, and as such we can manipulate the type of screening that we would recommend for these patients. I saw something in the chat a second ago, is can patients be screened or participants be screened outside of Europac? Yeah, of course they can, but the trouble is Europac is the only standardized informed way that actually gives patients a chance to get the best, most useful type of screening. Next slide, please. And then the screening surveillance arm is called PRIME, which is what Emma and her colleagues at NHS England have funded for us. So this is the ability to offer all predisposed individuals a standardized screening methodology with cancer surveillance navigators put into screening sites to standardize the program and feed all information back to us, and allow a functioning national MDT between Europac and screening sites and patients, such that everyone is getting a harmonious care. Next slide, please. So just to put that into context, as Emma's just said, about 10% of all pancreatic cancer will be genetic. If we couple that with the pancreatic cancer that we know come from pancreatic cysts, which is separate but allied, and then if we also couple in screening programs for new onset diabetes in anyone over 50, actually we're more than halfway, we're more like 3/4 of the way in all of the avoidable causes of pancreas cancer if we actually capture these patients and survey them. So there's good news out there, but we're not quite there. Next slide, please. So Europac is the European Registry of Hereditary Pancreatitis and Familial Pancreas Cancer. So familial pancreas cancer can come from you or the individual or the participant having a germline mutation. So that's a mutation that you're born with through your family. And here are some examples. And essentially what all of these things mean, especially those that affect P53 and P16, is they're all very central to the cell cycle. And that means that your cell cycle is dysregulated and is likely to produce a cancer. So anyone with a family history of pancreas cancer and one of these mutations is automatically eligible to be screened in Europac. Next slide, please. However, most patients don't know whether they have a genetic mutation, or maybe don't have a known genetic mutation because they haven't been tested for, so rely purely on their family history. So if you scroll down to the second line above the bottom, and there's a little triangle next to a square, if you're that individual, you'd want to know what your risk of pancreas cancer is, and you can see that that their sibling has pancreas cancer and one of their parents has pancreas cancer, so their risk is actually quite high, and this is what we get all the time. So those are two examples of what we do. We work out a family tree, we work out a family risk. Next slide, please. And then at the moment, slightly complicated slide, but it's not as bad when you look at it. Essentially, patients are referred either by themselves or by a second party into Europac. We build their family risk, we build the family tree, and then we work out what sort of screening they should have. At the moment, for someone with familial pancreatic cancer, the entry requirement is a CT scan, just to check that they haven't got cancer already. And unfortunately, some people do. And then it's annual endoscopic ultrasounds with the addition of an enhanced MRI scan on every 3rd year. Now, if you have a mutation on top of that, that will increase your family risk markedly. So we would recommend actually more enhanced screening, such that instead of an MRI every 3rd year, you get an MRI every year and an endoscopic ultrasound every year, because these are the patients that we're really quite worried about. Next slide, please. The other group we screen is hereditary pancreatitis, which you may or may not have heard of. So these are patients that carry a mutation within a gene called catalytic trypsinogen. These patients will get pancreatitis, recurrent pancreatitis from childhood, and so by the time they reach adulthood, they will have overt signs of chronic pancreatitis. But the take-home message is that because of the ongoing inflammation and the genetic instability, these patients carry a 40% lifetime risk of developing pancreatic cancer. So we're very interested in screening these patients as well. Next slide, please. And these are screened slightly differently from the familial pancreatic cancer, because endoscopic ultrasound and MR is less valuable due to the intense calcification. So these patients are mostly screened by CT scans, usually every 2nd year, unless the participant becomes diabetic or they continue smoking and drinking, which is likely to amplify the process. Then we add in an alternate year MRI scan, but we don't use endoscopic ultrasound at all, because that is known to be very unreliable in the presence of calcifications. Next slide, please. So as Emma said, the 3 main referral mechanisms are here. Secondary care through MDT.
Chris, I think you've muted yourself, sorry.
Sorry. Through secondary care, so that's anyone dealing with pancreas cancer patients or their relatives. Through genetic services and through primary care. But as Emma said, the majority of patients that we get self-refer, which is absolutely fine. Next slide, which I think is the last one. Next slide. Yeah, so we have our navigators, which are embedded into all of the screening sites. So they have a local role within the Cancer Alliance, which acts as the hinge between that Cancer Alliance, those trusts, and us. They have a national role which updates us on what is going on, so that we can carry on our research and refine the screening capacity, and also they will prepare the MDTs for the regions. So at the moment we would have probably 3 national MDTs, North, Midlands and South, and Emma, just close your ears for 2 seconds. We'll also have a devolved nation MDT outside of England. But I think that's probably enough to say at the moment, and we can pick up any further points as we come along. Thank you very much. Kat.
Thank you, Chris, for that brilliant overview. There were a couple of questions and we're slightly ahead of time there, so I don't know if we just want to take those now. So just there in the chat, I think you answered the first one around surveillance and being part of the Europac study. And then there was a question around family members and age range of eligibility for inclusion.
So age, we would normally screen at age of 40 unless the age within the family is much less than that. So for example, if we're finding several patients in the participants' family are getting pancreas cancer in their 40s, we would screen them a decade sooner. And we screen up to the point that it would be feasible to undertake treatment. So we'd screen an 80-year-old if they were fit for surgery. We wouldn't screen a 50-year-old if they weren't fit for surgery. So age is not a definite barrier.
Thank you, Chris. And there was another question there around navigators being only funded for 12 months and who's intended to do their role after.
Well, that's an interesting question. I might leave that to Emma to answer, but we've got to prove to Emma that this is a useful process. Okay, so we are doing lots of road shows and hopefully advertising our system such that actually it becomes a necessity to carry on funding this.
Lovely. Thank you. I'll let Emma come in on that at the end as well then. But thank you ever so much. A huge thank you. So I'm going to welcome Dr. Helen Winter next, who's a consultant medical oncologist and the clinical director at SWAG, who's going to give us that secondary care clinical perspective and experience. So thank you, Helen.
Yeah, thanks so much, Kat, and great to see so many people on the call. This is a real opportunity for us to really impact on this early detection. So I am a HPB oncologist. I've just been in a busy HPB clinic and sadly seen 2 patients who've presented with advanced pancreatic cancer today. And only last month I had 8 patients in the clinic and 7 of those had advanced disease and only 1 of them was being seen with curative intent. So behind those facts and figures and the absolute necessity to do that are patients presenting. And next slide, please. And although we've had dramatic inroads to many of our clinical outcomes and improving outcomes and new therapies on the horizon, sadly, pancreatic cancer, we've tried a lot of different things, but the current trial that we have in metastatic disease is still novel treatments of novel combinations of chemotherapy. So this diagram just shows actually CAR-T, which is showing some promise in solid tumours. Whether it will come to advanced pancreatic cancer, that may be the question. We also hear that cancer vaccines may be coming post-surgery, and we're watching this space. But as Chris and everyone has said, we would much rather pick these cancers up earlier, or in families with an inherited risk, prevent it altogether. And I think it is all our job, and I challenge all of us now to get behind this and ask people the simple question of, is there a family history? And if so, there really is no excuse not to mention Europac and consider referring. So watch this space about improving treatments of patients with advanced disease or potentially after surgery. But as an oncologist, I think much more likely to make a bigger impact is this earlier detection of cancer. And I think this offers us a huge hope for many of us who've been in the field for many years. Next slide, please. So I've just put a link into the chat of a video, and this is really about what you need to know. And an amazing patient, Graham, who's sadly no longer with us, but he made this video for the Clinical Research Network, and he was on the trial that I've just been talking about of novel combinations of chemotherapy. And he explains his journey whilst having taking part in a trial. But sadly, as I said, although he did very well on the trial, he is no longer with us. He presented with advanced disease, and all we could do was try and control the disease. So he explains, one, the benefits of taking part in a trial, which I think hopefully we can ensure that anybody who's presenting with these type of cancers is offered a trial, but also the importance of telling patients and having conversations that research is ongoing and that we are trying to do better. And I think Europac, as I said, really offers hope, even when we're seeing patients with advanced disease, that there may be some help for their family, and that a family member may be avoided, may avoid the inevitable outcome that happens if you've sadly got stage 4 disease. So I really urge you to go and listen to Graham. He actually, it isn't a depressing video, but it really explains what it's like to take part in research. But also, sadly for Graham, he presented with advanced disease. So that really tells you about why I think we should take part in research, and also what happens if you've got stage 4 disease. Next slide, please. So this is a bit of repetition, but I think it's really important for us all to note this isn't doing something special. This isn't a luxury add-on. This is fundamental to what we should be doing, and that there's nice recommendation out there that we should be looking for these patients and referring them on. So that's just to recap. And I mean, Chris showed all those very fancy sort of algorithms and the amazing work that they've developed. But for us out here in secondary care or primary care, we don't have to even be as clever. All we have to do is have the courage to mention it and ask the question. So there's a real challenge for all of us, whatever your role. Don't be frightened. Cancer genomics can be scary, trying to explain all those things that Chris mentions, but we don't have to do that. All we have to do is have the courage to ask and mention it, give them a leaflet, or even better, talk to one of the navigators and pass on their details. Next slide, please. And as Chris mentioned, this has been open for a long time, but people have been self-referring, and that's all well and good. But actually what we are committed to do is reducing health inequalities and ensuring there's equity of access to research. So for those of you who are not familiar, do get familiar with the Core 20+5 framework. And this is, again, another thing that we should really be embracing and saying we want opportunities for all. Obviously, people have the right to decline, but do not make assumptions that certain people or certain people from our communities do not want to take part in research. They do want to take part. They just might need some more time, some explanation, and just making sure that we are explaining it in a way that means that we are not hard to reach. So just have a look at that. And so that's really, really good that we want to ensure that we mention it and don't make assumptions about people. And then I think the next part was what do we do next? So next slide, please. So all we need to do is just ask people. So this is hopefully full of multi-professionals. Don't be worried if you're the only one that's mentioned it. We're all very busy. Everyone's feeling overwhelmed. But it just takes a minute to ask. And you literally just need to say, do you have a history of pancreatic cancer? Or as I said to the lady last week, who I met again today, do you have a history of pancreatitis in your family? I was not aware that pancreatitis or inherited pancreatitis risk was even a thing, to my ignorance. And I did, and she had 2 family members. So she's been put in touch with the navigator today, and she's got family, siblings and children who I think will be eligible. Obviously they need to go through the complex algorithm, but it just took me asking that question, and they didn't have a history of pancreatic cancer, but they actually did in pancreatitis. And I couldn't believe I've just learned that, I've just asked it, and then they've referred them. And then obviously, because we know there are associations with BRCA genes as well in pancreatic cancer, early cancers at a young age, early breast cancers or ovarian cancers, and Lynch syndrome, and so endometrial and colorectal cancers. But this is going to become part of our normal conversation. Family history has always been part of a medical history taking, but now more than ever, we really need to brush up on how we do that. So next slide, please. So where are we going to do it? Well, I just think we just do it everywhere. We just embed it into our conversations. So primary care in the community, MDTs. So there's been a bit of question, oh, our MDT is very busy. I'm not sure that we can be picking up patients who might have a family history. I think we challenge that. Just as we've had Lynch syndrome champions in our MDTs for colorectal and endometrial cancer, I think we need Europac and pancreatic cancer champions in our MDTs. Even if you're the most junior in the team, does it hurt to say, would they be suitable for Europac? Has anyone asked them about a family history? You could really be changing, you know, a life and impacting on a family. Asking at a new patient appointment, whether you're a surgeon, whether you're an oncologist, whether you're in palliative care, and I'll just say a bit more about that in the moment. All our nursing colleagues, they've been mainstreaming for Lynch syndrome and BRCA, and I would say this needs to be part of that conversation. It's everybody's business, it's everybody's job. And we had a meeting, I think with Emma and Chris a couple of weeks ago, and we were, and somebody said, but a lot of these people, I think it said up to a third of people don't even get to see an oncologist. They go straight to palliative care. So I said, oh, well, maybe our palliative care colleagues should be asking at the hospice, and we've got an enhanced support team. And within a week, I sort of mentioned it to them. They'd spoken to a daughter, father very ill, but wants to take part, want to make sure that that doesn't happen to any more members of their family. So we know that a lot of our patients sadly don't have active treatments, but the opportunity for something good to come out of a diagnosis of pancreatic cancer, do not underestimate it. And even if someone's quite poorly, we know that they usually are happy from an altruistic point of view or from their family point of view. They will take part and they will agree. That I just took that picture from the Pancreatic Cancer UK site, but it doesn't have to just be about people on active treatment, because we know we'll miss out people on that. Next slide. I think I've got two more. So this is we just did a meeting with our local clinical research network about are we hard to reach? And this is Huda from Afi Health, part of our community engagement. And she was just saying, look, let's just get out there and engage with our communities, and don't make assumptions about who might or who might not take part in research. And then finally, my final slide. This is Graham when he went on a cruise, when he was taking part in his advanced cancer trial. He always used to come and do something nice after his appointments with us, either go to the casino sometimes or go and have a meal. And then he went to a cruise. I think this was in Scandinavia. So I really want to thank him for really showing me what it meant to look after a patient on a clinical trial, and really amazing teamwork. Sharon Short, who's my colleague who we've just been consenting patients for in clinic, and our CTU, Chris and his team, and also the national team, Meg Finch-Jones, who's our local PI here, Tracy Miles and the GLH and GMSA, because we're trying to look at a way of highlighting if people have got rare mutations that they might then be eligible. So we've entered somebody who had a rare mutation and a strong family history of cancer, making them much more likely, and they've been referred. And then our community partners. And finally, thanks to Lee for reaching out to us and giving us this opportunity. I'm absolutely thrilled to take part, and I know we're going to refer more people, because it's just a fantastic opportunity for our patients and their families. Thanks so much, Kat.
Thank you, Helen. That was a really powerful presentation, emphasising how important it is for us all to be involved in this, and it's part of all of our jobs. So yeah, thank you very much for highlighting that. I think it really shows how we can improve things and change the story going forward if we're all involved. So I'd like to introduce Peter De Rosa now, who is the Policy and Health Improvement Manager at Pancreatic Cancer UK, and he's going to give us an update on their work at present. So thank you, Peter.
Thank you so much. I'm assuming, are you able to see my slides? Is that all working well?
Yeah.
Take that as a yes. Great. Thank you for letting me speak today. Yes, I'm Peter. I'm the Policy and Health Improvement Manager at Pancreatic Cancer UK, and I lead our policy work around early detection and diagnosis. So I'm just going to give a really brief update around what Pancreatic Cancer UK have been doing in this space. So Pancreatic Cancer UK have been supporting the Europac programme and they're running the registry since 2017, and we've recently committed to continue our investment into the Europac programme, as this is a really important strategic area of focus for us. And over the last year, we've also been working closely with Europac and NHS England as part of this new pilot programme. So as I say, as an organisation, we've recently produced a new 5-year strategy, and a key part of that strategy is looking to continue to invest and collaborate with teams to improve monitoring programmes for people at high risk, particularly family history of pancreatic cancer. And so we know that there have historically been no national programmes for pancreatic cancer, and that this is currently the only at-risk group that we can currently offer any form of routine surveillance for. Therefore, I think it's really important and really essential that we take advantage of the momentum of this first NHS England programme in pancreatic cancer, and ensure that there's really great engagement and recruitment to this pilot, to ensure that it's successful and that we can continue it long term, and that there's a lasting legacy for people with pancreatic cancer.
Are you working Monday, Tuesday, Wednesday?
Sorry, can I just ask that anyone who's not on mute can just pop themselves on mute? Thank you.
So I think, as has already been touched on so far, this programme could really start to help shift the stage for diagnosis or early detection for pancreatic cancer, and could lead to a 6.1% stage shift, which really would be huge progress for this disease. As we've heard so far, Europac offers a really important service for people and families affected by pancreatic cancer. And as a national charity, there are so many people that come through to us through our support line or through our fundraising activities, who speak to us and they say, they've had 2 or 3 family members with pancreatic cancer, and they're really concerned about what this means for them and what this might mean for their children. And they come to us and they want to know if there's anything more that can be done for them. So there really is a large pool of people out there who we haven't reached historically, but now is a great opportunity for us to reach those people and ensure that we are telling them about this inherited risk and offering them the opportunity to be referred onto the Europac programme. I think we also recognise that it is hard to always get this message out to patients and healthcare professionals, particularly in the context of all the other priorities in the healthcare system and the other needs that families face at the point of a diagnosis. And I think that's where Pancreatic Cancer UK can really provide support to help to amplify the message, amplify the way we're talking about inherited risk, and to ensure that more people are aware of it. That's why Pancreatic Cancer UK will be working with NHS England and Europac over the coming months to help to support this pilot, and we'll be working on an exciting project nationally to think about new ways that we can increase awareness of inherited risk among patients, increase awareness of inherited risk among health professionals, and think about new ways that we can boost recruitment into the Europac programme so that it is as successful as possible. So I just wanted today to kind of flag that this is an area of work that we're doing a lot of work on at the moment, and it's something that we as an organisation will be doing a lot on in the new year, and that we'll come back to you hopefully in the new year to show you what we're doing in this space. Thank you.
Thank you very, very much, Peter, for sharing the work that's being done by Pancreatic Cancer UK. I think it's so important to have the collaboration that's going on and hear about everything that you are doing and the support that you offer to patients and family ongoing. So thank you for that. I would now like to welcome Kim Kay to speak to us, and thank you very much, Kim, in advance for sharing your story. I think you're just on mute there, Kim. Sorry.
Hi, everybody. So just very briefly, I wanted to share why I'm here with Europac today and what brought me here. My mum was diagnosed with breast cancer when she was 57 years old, and she didn't want to take a test at the time to see if she had any genetic mutation, because I think she was quite worried what that would mean for me. So she didn't do that. Unfortunately, she then was diagnosed with pancreatic cancer at the age of 69 and died very, very quickly. As we all know, there's not a great deal, if it's found at a late stage, as to what you can do. This really scared me. I was terrified, but at the time I was living in Australia, and unfortunately, if you have a pre-existing condition, you're not covered by insurance. So I also didn't take the test to see whether or not I had any sort of genetic mutation. In 2018, I was diagnosed myself with breast cancer, and my oncologist said, and my surgeon suggested, that I did take the BRCA test because they would treat me very differently if that was the case. I took the test and I was positive. I went on for my treatment and I'm now 5 years cancer free, which is wonderful. Unfortunately, my brother, I only convinced him to take the test a year ago. He also has BRCA2, and he was diagnosed with cancer on Thursday, prostate cancer. It's going to be a very good outcome. They found it early, and again, this really brings home the early detection part for me. This is not a death sentence, this is a life-changing sentence, really. It improves everything about your life. You can manage your outcome by early detection and by taking control. Once I was diagnosed with BRCA2, I made the radical decision to have a bilateral mastectomy. I had my ovaries removed. I'm at a slightly increased risk of melanoma. So I now have yearly body mapping, which then brought me to pancreatic cancer and what can I do? So I went back to my doctor and asked, is there anything available? And he said, leave it with me, I'm not sure. He did some research and came back to me with Europac. And I am over the moon. So I went to see Europac in Liverpool, and I'm now going to be eligible for the trial and the screening. And fingers crossed, this should, I hope, change my future. I have 3 stepchildren who also lost their mum to cancer, and I'm determined that I'll do whatever I can to prevent this and bring awareness to this disease. And so that's why I'm here today.
Thank you so much, Kim, for sharing your story. I mean, it's a real privilege to hear your journey, and it really does drive home how important this work is and why we need to take action and ensure that we are supporting referrals into the Europac programme to pick this up and detect pancreatic cancer early. So, you know, I'm sorry to hear, you know, that it's an ongoing process for you and your family, but it's amazing to know, you know, how it's impacting you, and yeah, as clinicians, really gives us a kind of background to why this work is important. So yeah, really appreciate
it is, and I
you
think
taking the time.
It's important that we change the narrative of everybody thinking that you know, being diagnosed with a gene mutation or you know, the risk of pancreatic cancer, is a death sentence, and it's really not. And it's you're changing your life. It's like managing a business, but it's your health. And you know, if you do it early enough, there's a positive outcome.
Yeah, no, thank you for emphasising that, and hopefully we can change that narrative going forward. So really, really powerful to hear from you. So thank you very, very much for coming along today.
My pleasure.
We've got some questions, I think, in the chat that are there, so I will put them to our panel. As I say, if we don't get through everything, then we will look at them separately and compile a list going forward. So if we just pop up to, I'll just get those up on the top. So Chris, I think there was some for you there around guidance for information for MDT coordinators and their role as Europac champions.
I like that idea. I'm not sure that all HPB MDTs may see it that way, but I definitely would like that idea that there should be a Europac champion. We do have a healthcare pro forma, as it were, and we'll make sure that you've got a pile of those that you can send out. But it's just, I think almost as we're moving into the digital age, one of the important questions to have as an essential field in referring a potential pancreas cancer is there any family history, to be honest, and then that gets around it. But certainly, you know, if someone's piping up all the time, is there any family history? The MDTs will soon get to grips with that. So I found 2 this morning in my MDT. So you know, we'll take it from there.
Thank you, Chris. And then I think there was one around sharing details and the number of patients enrolled in Europac and how many cancers have been found, if you're able to.
So Annabelle does know that number, I don't. What we don't find a lot of is cancers. And that's a good thing, actually, in a surveillance program. You don't want to find a load of cancers. What we do find a lot of is what we call actionable lesions. So what they then end up going is going round through the MDT. They'll get MRI scans, they'll get MRCP scans, they'll get CT scans, they'll get EUS-FNA, and probably about half of those will turn out to be pancreatic cysts, IPMNs, mucinous cystic neoplasms, of which a portion will go on to surgery because of their features. Other things will be something that's been overcalled on either a simple EUS or an MRI scan, and some will be things that we think are early cancers or neuroendocrine tumours or something that looks highly suspicious, and we send off to their regional HPB centres or pancreas centres for surgery. So I think, pulling facts out the top of my head, we've found a handful of early cancers. Okay, but you know, if you're finding early cancers or pre, you know, or lesions with low-grade pannins in, or pancreatic cysts, or some area that looks funny, if all of that's taken out, then that's risk reducing all the time. So yesterday I was in theatre. I took a 28-year-old's whole pancreas out because she's got a PRSS1 mutation and hereditary pancreatitis. That individual has, on average, 4 or 5 visits to a hospital with chronic pancreatitis each year. It's getting worse each year, and she's obviously terrified about that risk. So we sat down, had the conversation over time, and we decided to take the pancreas out. So that's her risk zeroed now.
Amazing. Thank you for putting that into context so clearly for us. There's another question. I think you have answered this in the chat, but just for the benefit of others, in regards to referral for surveillance, why does it need to be 2 or more relatives with pancreatic cancer?
So if you just got one relative in your family with pancreas cancer, and let's hope you don't, that doesn't give you any personal risk above anyone else in the population. If you've got a second relative, that might change things, but it actually depends who that relative is. If it's a first-degree relative, which sort of goes on the vertical axis, it's much more likely to increase your personal risk than say a second-degree relative that goes across the horizontal axis, like a cousin, for example. But it also depends on how many people are in your family. If you've got a really small family, then you would actually only need one person in it to potentially give you something approaching a risk that allows you to be screened. So what I say, and Annabelle may scowl at me in a minute, is I don't really mind having any referrals. Please send me everything that you're worried about, and we will sift through and work out risks and tell you what we think. I don't want to miss anyone.
Thank you, Chris. Expect to be hopefully inundated going forward. I'm just going to go back to give Emma a chance to comment around the Navigator post for 12 months, because that was mentioned earlier. Emma, are you able to give any more information about the duration and intention of who might cover that role going forward?
Yeah, absolutely. So yeah, as we said earlier, so the Navigators are initially contracted for 12 months. This is a pilot, and it is all about understanding whether these referrals have been established, whether this is kind of the best way forward. I don't see I don't see this contract kind of changing significantly. And it's essentially, it's just all about kind of seeing what comes out from the evidence base and evaluating that. But we are, yeah, this is continuing at a minimum until I think it's August next year, and then we just need to yeah, assess the referrals.
Yep. So the more you refer in, the more we have a case to take to Emma. Sorry, Emma.
I would say it's not just me, but yes, absolutely.
And thank you both for giving clarity on that, and again emphasising refer. So will the navigators be communicating with cancer services teams in patients' local trusts, requiring discussion at MDT?
Difficult to answer. So the point of the navigator really is to collect referrals from the teams, send them to us centrally so that we can work out the risk, and then prepare the footwork for the national MDT, which will feed back to the local teams, or the MDT leaders it will probably be. In terms of feeding back to cancer services, I think that's from the Alliance, and the alliances are fed back the data from Emma and her team. So indirectly yes, but directly no, unless I've got that slightly wrong, Emma.
No, I think that's correct.
Okay.
Brilliant, thank you. There's a question there about sharing documentation with primary care colleagues. So obviously there is information on the Surrey and Sussex Cancer Alliance website that I mentioned earlier there, and information is going out in newsletters via our comms teams as well. I think, you know, we're hoping to reach primary care because they are an important part of this, and not to just make it feel like it is a secondary care onus and responsibility. So, you know, we have cancer champions in PCNs, and so this information goes out to them as well. So things will be shared for them through that. Just looking down, there's a lot of thank yous to Kim for sharing her story and being so courageous to come and raise awareness about this. So I just want to acknowledge those there. We've got a question around what's the easiest way to refer to Europac.
Easiest way is through well, if you go to the website, just put Europac into Google, you'll get it as the top hit, and that tells you directly how to refer in. And in future we'll have all the relevant documents on there. We're just finishing those off, and actually in the future we'll even have a patient app where the patients will be able to see all their appointment information and all their previous investigations all in one space, which the navigators will be their primary contact for. And Kim and her other colleagues in the Europac PPIE group are going to test that to destruction shortly once we've finished developing it. So by the time that's out, it will be almost unbreakable, we think.
Fabulous. That sounds very, very exciting development ahead. There's a question here around whether Europac could consider integrating a referral form into the GP system so that referral is part of the patient record and logged, just to avoid kind of the clunkiness with the paper side.
I'm sure it can be, but I'm not the right person to talk to about.
Shall I?
Yeah, do you want to go, Emma?
Yeah. So absolutely, it is something that I mean, I would love to do this, and it's something that we are looking at for next year, and it's as of hopefully early next year. So, you know, in a few months we'll also have a bit more capacity in the national team around on this. So we'll be recruiting two new roles that are focusing on pancreatic cancer. And so I also, the more people that ask for this, the more I can push for it. So it is also very useful to be getting that feedback, so I can continue to push for that for next year. Thank you.
Thank you, Emma. We'd very much welcome it. There's another question here, just saying that Kim's story really highlights the links to other tumour sites and what the plans are to raise awareness within other tumour site charities as well. Don't know who wants to pick that one up.
That might have to be Emma, I think.
Yeah, so I think right now we've been focusing on the pancreatic cancer charity, so obviously working with Pancreatic Cancer UK and also Pancreatic Cancer Action, and I think there is absolutely more opportunities where we can raise that with others. So we have our we have links in with Cancer 52 that are a conglomeration of many of the different cancers, and yeah, we'll absolutely be doing more to raise that with other charities.
Thank you, Emma. I think we've covered most of the questions that have come up, unless I've missed any. Is it all right just to pop our slide pack back up, and we will just say, while that comes up, it'd be really, really great to have feedback. So please do follow this link. There's a QR code there, and we'll pop it in the chat. But just an enormous thank you to all of our speakers again. I think this has been a really fabulous session, raising awareness and actually just really optimistic for how we can change things for the future if we're all working together. So it'd be really nice, you know, in 6 months, a year's time, to kind of hear an update of where things have gone and what the future thereafter holds. So I really do just want to say a massive thank you to everybody for joining today, and in particular to Emma, Chris, Annabelle, Helen, Peter, and especially Kim for coming along and speaking to us. If we could just flick to the next slide. So yeah, just an acknowledgement of everybody who is involved. So we don't do this work in silo, and it is very, very collaborative with all of our partners. So a massive thank you to anyone that I haven't already mentioned on that list. And then finally, the next slide, please. Just a thank you again. We will look at all those questions and compile a document to be sent out with the slides in due course, and any further questions that we've missed, we will answer those as well. But yes, thank you ever so much to everybody for taking time in what I'm sure is a very, very busy day, and coming along, and especially to our speakers. It's been incredibly informative, and I've certainly learned a lot from my position. So yeah, enjoy the rest of your day, and thank you again.
Thank you very much.
Thank you.
Thank you.
Thanks, Kat. Thanks so much.